So despite having very good machines, we can sometimes have this problem of excessively deep anterior chamber during the cataract surgery, which makes the surgery really very challenging, because it's difficult, very difficult to reach the surface of the cataract without severely tilting the phacoemulsific, and doing that you can severely tilt the wound, and there will be distortion of the cornea, so visibility will be very poor or can be compromised. And it may cause sudden, actually significant discomfort to the patients when the patient is being operated under topical anesthesia. If the chamber suddenly deepens, then patient may have pain. So this is a small clip of a patient with very high myopia. You can see it's not moving. This video is not opening.
Audio visual.
This was loaded yesterday there. नहीं होगा 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 हाँ हाँ. So the moment I entered into the anterior chamber with my phaco handpiece and started the fluid on, you can see, just observe how the chamber deepens so deeply that it is actually difficult for me to place the phaco probe in the center or do any kind of sculpting or any maneuver. It is almost 75 degree of axis at which the phaco probe is being actually held. So it's really very difficult to do phaco in such situation. What could be the causes? The most important is the high myopia, post-vitrectomized eye, or if you have kept the infusion pressure very high, if you have kept the bottle height very high in machines with the gravity fed system, or if you have overfilled the chamber with the retentive OBD like Helon, where there is approximation of the iris on the anterior lens capsule, which is actually not allowing the iris to just get separated from the lens capsule, that can also lead to the excessive deepening, or there is excessive softening of the globe, or if posterior capsule chamber rupture happens during the surgery. So it was Jauberman who first described anterior chamber deepening with the dilation of the pupil and bowing of the peripheral iris, which was subsequently named as lens iris diaphragm retropulsion syndrome by Wilbrandt. So what is that? It is actually reverse pupillary block. Once phaco tip is introduced into the highly myopic eye and the inflow is activated, the anterior chamber deepens and the lens iris diaphragm actually is pushed posteriorly or downward. Iris becomes concave and there is 360 degree of irido-capsular contact, and which actually leads to the dilatation of the pupil due to the pressure of the water column. And how to come out of this situation? You have to decrease the bottle height and reduce the pressure in the anterior chamber. A side port instrument is introduced through the side port, as such like iris repositor. You can use the Sinskey hook also, and it is placed under the iris to lift it gently. This is called Sioni maneuvers, which breaks the pupillary block and equalizes the pressure between the anterior and posterior chamber, and at AC then resumes a normal depth, and you are able to do the phaco as the lens comes into the normal positions. This is the small video clip of high myopia. You can see here the moment I went inside and started the fluid on, you can see the pupil dilates, the chamber becomes so deep and pupil dilates because there is reverse pupillary block. You are able to see even the zonules in the periphery. So I am taking the iris repositor just below the iris and then it actually aborted the pupillary block, and now I am able to do the surgery in this patient. This patient was had high myopia. So in high myopia, you always actually be observant that it should not have very large fluctuation of the anterior chamber. So I am injecting the viscoelastic before taking out the irrigation. That is very important in these cases. This is +4 diopter of the single pieces lenses has also started coming into the market, less than 5 diopter, which was not earlier. So this is from Optic Flux. So I have implanted in this patient, and this is another case. It is post-vitrectomy eye. You can see the port scar here and this side also. And the moment I went into the anterior chamber, again the same thing happens. So here again I am going to use the iris spatula, or you can use any other instrument just to reverse this pupillary block, and then you can go ahead with the phacoemulsification. Another one which has already been shown by so many previous speakers. This is a case of very hard cataract. The two halves were made, but while I was trying to do the third, the chopping for the third piece, suddenly there was a deepening of the anterior chamber, and that gave me a clue that probably posterior capsule rent has occurred. So you can see, you can observe here, suddenly the chamber will deepen. So this is one of the signs of posterior capsule rupture. Another case, everything was going so smooth without any problem, but while I was removing the last quadrant, suddenly there was posterior capsule rent, and this is actually, the posterior capsule rent actually produces the sudden deepening of the anterior chamber with pupillary snap sign with increase in glow. You can see, you will able to see the increase in the glow here and the pupillary snap also. So this can happen if there is posterior capsule rent, you can have sudden deepening of the anterior chamber. So here, before taking out the handpiece, you have to inject viscoelastic through the side port so that there is no further extension of the posterior capsule rent, which is so essential in these cases, as highlighted by Dr. Love. And then again, then I went ahead with doing the anterior vitrectomy. I won't go into that detail. This has already been covered by previous speakers. So how to prevent? When the phaco needle is introduced, it is always better to introduce with the irrigation off mode. And once you are there, then you put it on. Before it is switched on, you introduce a second instrument through the side port under the iris to lift it slightly. This has been suggested by Richard Packard. And every time whenever you enter the anterior chamber, it has to be repeated unless you have removed the actually nucleus. The newer machines, the active fluidics is really very beneficial in these situations. You can actually monitor the intraocular pressure. You can keep the machine's intraocular pressure very low so that there is no deepening of the anterior chamber suddenly. And also you can modulate with the rise time. Rise time is the time taken for the pressure to rise in the given machine, where you can modulate it and you can let it rise slowly. This is one video clip using the active fluidic system. Here, earlier surgery was being done 55, now I am doing under just 20 millimeter or 24 millimeter mercury. I have introduced the phaco tip. You have hardly seen any fluctuation of the anterior chamber in this patient. This is patient of high myopia with cataract. And while chopping and removing the quadrant pieces, there is no undue fluctuation of the anterior chamber, just like in any normal cataract patient. So even with the intraocular pressure of 22, I am able to do the phaco without any problem and with all ease and all comfort. So that is very important facility now available with advanced machine, where you can handle all such type of cases. Here again in the myopia, you would not need, this is -10 diopter of lens. You can see that the patient was quite highly myopic patient. So even in this patient, I was able to do surgery without causing undue deepening of the anterior chambers. So thank you very much.
Thank you so much. One thing what Dr. Arun was saying, that he uses the IOL scaffold when there is a PC tear. Would there be a chance that when you're putting the phaco probe once again, that the scaffold that you have put as an IOL may also go down? Because I use this scaffold when I have an IOL crack. So I put a IOL first and then remove the IOL which has broken.
Actually, one has to try it, put in the sulcus, and even you can just keep the one leading, the trailing haptic outside the wound also. That can also, or even you can place it over the iris. The two haptics lying on the iris, that is required. You never try to go blindly, because if there is nucleus piece in the anterior chamber, you are not able to see the sulcus properly. So it's better to put in over the iris below the lens, and use this chondroitin sulfase to protect the endothelium and to create some space between the nucleus and the iris or anterior capsule. That actually guides.